Hello, our webinar will begin in 1 minute. The webinar will begin in 30 seconds. Hello, welcome to the National Consortium of Telehealth Resource Centers Telehealth Hacks Series. Today's session will be Building Lasting Telehealth Programs on College Campuses. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy. Next slide. The NCTRC Telehealth Hack Series will not share your information that you've supplied to us for registration, so please know we will keep your data confidential. Next slide, please. The National Consortium of Telehealth Resource Centers is made up of the 14 telehealth resource centers who are funded through a grant from HRSA. There are 2 national centers, one on policy, which is CCHP, and one on technology. And there are 12 regional resource centers that cover specific states. Next slide, please. The Telehealth Hack Series began as a series this past summer underneath the auspices and the offices of ASPR. The series was handed off to the Telehealth Resource Centers in mid-October, and we've been continuing the series and we'll continue through it through March of 2021. Next slide, please. A couple of tips and notes for today's webinar. Know that your phone or computer microphone has been muted. If you have a question for any of our panelists, please use the Q&A function. The chat function should only be used for technical questions or issues that you may need information for with Zoom. Attendees are able to adjust their video sizing using Zoom's sliding feature. And if you require it or would like to use it, closed captioning is available in the toolbar. Note that today's webinar is being recorded and will be posted on the Telehealth Resource Center website as well as our YouTube channel. Next slide, please. Continuing education credits are available for today's session through the University of Arkansas Medical Center. This is their disclosure policy. Next slide. Additional disclosures on the staff who had planned this session. Next slide. And the joint accredit and credit designation statements. Next slide, please. If you are interested in receiving credits for today's session, you must go to the Learn on Demand website where you must establish an account. You only need to do this once. So if you have requested continuing education credits for previous hack sessions that the TRCs have hosted, you do not need to do this again. But if you are a new user, you will need to create a profile on Learn on Demand, and then it will take you through the process on how to receive credit. Next slide, please. And then this is the URL for it. You search for the existing topic, and then it will lead you to where you will be able to request your certificate and credits. Next slide, please. The deadline for this session in order to do the evaluations is Monday, December 21st. So please note that date. Next slide, please. And this is additional information. The slides will be made available after this session, so you will be able to refer back to this for information. Next slide, please. So today's agenda, we'll hear first from 3 great speakers, Michael Deichen, I apologize if I am saying that, mispronouncing that, then Kimberly Tilley, and then August Jordan. We'll have time at the end for some questions, and also our moderator will allow questions to be asked between presenters as well. Next slide. And I would like to introduce our moderator for today. Dr. Christian Ramers is Chief of Population Health and Director in Graduate Medical Education at Family Health Centers of San Diego. It's a large FQHC serving nearly 200,000 medically underserved individuals throughout San Diego. He is board certified in internal medicine, infectious diseases, and addiction medicine, and is particularly interested in HIV, HPV, HCV, and service of medically underserved and refugee populations. He is co-chair of the California chapter of the American Academy of Medicine and has advocated for HIV, HCV care at the state legislative level. So I will now turn it over to Dr. Ramers.
Great, thank you so much, May, and good morning to everybody. If we could get the next slide up, and I'd be happy to introduce our session here. So we have a great hour planned for you today, really focusing on college health. And we've got three really unique perspectives from around the country. So the first, I'm going to introduce each speaker just kind of as they come up rather than take all the time right now. Please do submit your questions via the Q&A button on the bottom, and we'll be responding to those and hopefully filling the time later in the hour with questions and answers. So without further ado, I'd like to go ahead and start by introducing Dr. Michael Deichen. He's the Associate Vice President of Student Health Services at the University of Central Florida. And in this role, he gives oversight to student health. This is a very large school. So our first perspective is going to be from the larger universities. I just went to Google and it told me that we're around 65 to 70,000 students enrolled in that school. This past year, he's directed the implementation of telehealth services, which has been used successfully by his staff to provide care during the COVID pandemic. So I'll turn it over to you, Dr. Deichen.
Thank you, Dr. Ramers. It's a pleasure to be here today with all of you. And each school is a little different. The University of Central Florida is a large state school. We have approximately 69,000 students. We are accredited. We have in excess of 70,000 patient visits per year. The picture is of our health center. We have 2 satellite offices as well. We provide a range of services from primary care to sports medicine, gynecology, psychiatry, dental, physical therapy, and pharmacy. And that's my staff with our Vice President of Health Affairs and Dean of the College of Medicine. We are part of an academic health science center, and our electronic health record is eClinical. So that gives you a snapshot of who I am and what our program is about. Next slide, please. So thank goodness for telehealth, right? I wouldn't have pictured a year ago I'd be saying something like that. We had thought for a long time about implementing telehealth, and we had flirted with it through an insurance vendor we have that provided telehealth after hours. But when COVID arrived, we had to do something different. We're prepaid for one thing. Our students pay a health fee, and we're obligated to continue to provide care, whether we see them in person or not. We have to find a way to take care of them. And so in March, the campus closed, and we had to resort to telehealth. And we only had 2 or 3 weeks to go from in-person care to telehealth services. And then our providers practice remotely from their own homes or other residence. So I think you all are familiar with the various parameters I've listed up here of why telehealth was advantaged in this situation. And again, we're just very fortunate to have had that opportunity with telehealth. Next slide, please. When we started deciding, well, how should we do this? Fortunately, at that time back in March, the Office of Civil Rights had reduced its enforcement on penalties associated with HIPAA violations, because that was a potential concern, and allowed for any non-public facing remote communication product. As a university, we decided to use a HIPAA compliant product and actually with a business associate agreement. But these are the most current HIPAA compliant products on the market. I updated it last week. And also there's a web address that you can look and update yourself as necessary. But you can see there's a lot of different opportunities. Next slide, please. So, when you engage with telehealth, a very important principle is to understand, you must understand the difference between an in-person and a telehealth visit. And it sounds so simple on the surface, doesn't it? That essentially with a telehealth visit, you're not able to do a direct exam, and with either a direct visit or with a telehealth visit, documentation remains the same. You need to have your SOAP note and your past medical history and all the other vital elements of a note. But there is a potential slippery slope with telehealth that you have to be cautious with. And in my opinion, you should avoid circumstances where a patient may be unstable, have a significantly acute condition, whereby telehealth would not be appropriate, or where you need to have a full examination of the patient in order to make an appropriate diagnosis. And sometimes you may be aware of that at the time of the appointment. It becomes apparent even to our appointments persons that this is not the right vehicle for a telehealth visit. At other times during your encounter, the patient may destabilize. They may become short of breath, or in other ways decompensate, and you have to be ready to shift to another means with emergency services and 911 if necessary, because telehealth does have its limitations. Next slide, please. So emergency protocols are very important. And for us, one of the first things we do when we make an appointment is we assess where the patient will be. What is their address? And you want that not only so that in case there needs to be an emergency intervention, but also you want to ascertain, are they within the state, as we talked about earlier. You also need to be prepared. One of the great tools that we have found here at the University of Central Florida for telehealth has been with psychiatry and counseling. Our patients really have enjoyed engaging with their providers via telemental health. So like any type of examination with those providers, potentially the patient may be at risk of harm to themselves or others. And you have to have a plan for what you may do if that's ascertained during the course of your exam. That's why you need to know where that patient is, so that theoretically you can engage with police or emergency services in that area, or obviously advise the individual to seek care. You also have to pay attention to physical signs of decompensation and be prepared for emergency steps, and have a means by which you may contact local EMS. Next slide, please. So, practicing across state lines, and this has been challenging also. It's interesting, Health and Human Services allowed for practicing across state lines via a waiver that they executed March 17th. However, our licenses are directed by the state. And so it's caused a lot of concern and confusion. There is an interstate medical licensure compact that some persons are choosing to use that gives them a license with 29 states. But really, it comes down to you have to be aware of the state requirements, mainly where the patient is. And two of the other speakers are going to discuss this in more detail. At the University of Central Florida, most of our patients reside in state, so this hasn't been a difficult problem for us, but it's something that all of you need to be cognizant of. Next slide. So for us, we chose to go with the Zoom for Healthcare product. And our logic was that UCF already had a Zoom contract with a business associate agreement. Our students use Zoom for classwork, and they're very agile with it. It was a simple step for us to install a Zoom application on their laptops, and that was great. And our providers found that they could use their laptop with a single screen to engage with Zoom Healthcare. For us, we also schedule every half hour. It's a bit cumbersome in some respects, in my opinion, compared to in-person care. Our providers had to do more administrative tasks when they're engaged with patient care. Normally, our visits are just 20 minutes, but with telehealth, we scheduled them every half hour, so we lost some efficiency there. Our students, on the other hand, found it very intuitive to use the product. Next slide, please. So it was amazing when we went from in-person visits in March to telehealth. Within a very short amount of time, we were experiencing 100 visits per day via telehealth. And we've had we've been still having up to 3,000 visits per month that are telehealth. We're gradually moving to more inpatient care, and I'll talk a little bit about that. But this was something that was extremely well utilized by our students, and it makes sense. They're so connected with the internet and IT, and they're using their smartphones and laptops, and it's really been easy for them. We've also found it easy to prescribe and use lab orders. And we already have an electronic health system that has made that easy to do regardless. We did find that we had to start our visits promptly, because there's a hard start for each of these visits every half an hour. And so it was important for our providers to end on time and start on time. So that's taken a little bit of discipline in certain situations. We also found it was helpful for our providers to be able to speak with each other about things that worked and establish best practices for the health center. I think that's really important, that dialogue be allowed and be made use of. It could be that using a portal would be easier than the way we did it. We balanced using Qualtrics, electronic health record, and Zoom for healthcare. All three of those had to be used by our appointments clerks with 2 screens, and that's a bit challenging, but they did it. It worked fine. Next slide, please. So we started phasing to in-person visits in June, and we prioritized those that were more important for us to see in person. We also screened diligently for COVID at the time of the appointment, at the time they arrived, at the time they had their vital signs taken, and all the other good things you would do to keep risk low related to COVID. And we prioritize also persons that maybe couldn't access telehealth or at a health provider's discretion. And with that, we were about 25% in-person visits in June. We've moved up to 50% as of August, and we've stayed at that level. We have a committee called the COVID Patient Care Committee, and it's made up of myself and some of the provider staff. And we've developed a procedure where we make decisions by consensus about when to expand inpatient care or contract it, for example. But right now we're holding at that 50% level, waiting for the vaccine. Theoretically, if things were to get much worse, or there was to be an outbreak in our health center, we could back down from where we are. Next slide, please. So, we're finding that balance between in-person telehealth visits and deciding on what's the best balance with our COVID patient care committee. And really, the patients have told us when to shift. We just found out very naturally that when we were all telehealth, there was an inherent need for some in-person visits, and we found that balance at 50% visits. And we developed a committee to make those decisions. Really important that the boots on the ground people have a significant voice in those decisions. Their health and well-being is at stake. So we have to make sure that we do things right. And next slide, please. And I guess, Christian, we can open it up for questions or move on to the next speaker.
No, thank you so much, Michael. I think we have about 2 or 3 minutes for questions, so we'll do just kind of a rapid fire round here for you. The first one comes from Carlos Banegas, directed to you, which is, what has been the most common mental health conditions treated on your campus during the public health emergency?
I would say it's pretty clear. It's depression, followed by anxiety. I can't say that there's been a shift in that, because those are 2 of our most common mental health conditions. They are more common now, though. It's affecting our students. So it's just been so great to have telemental health. When we look at productivity of our various providers within the clinic, our mental health providers have been the most productive. There's been a real need for them to be engaged.
Great. And another question came in about needing to start and end on time. You really emphasized this. Can you say why it was so important to start and end on time?
Well, there's this queue, there's this queue where patients are scheduled every half an hour and they're online. And so it's a little different than in-person visits where people are in a lobby and I guess they're used to waiting sometimes. If you don't finish on time and you go into the next appointment slot, then that's going to shorten the availability for that patient. They might leave, you might miss them, things like that. It's really important to stay on time, to maintain productivity and just really patient satisfaction. I didn't mention that our patient satisfaction has been above 90% throughout. We do a survey periodically and the patient satisfaction has been great. So that's probably one of the elements to try and stay on time. But it's more important in the telehealth world than in-person world based on my experience this year.
Okay, great. Thank you. And thanks to everyone for sending your questions in. That's about all we have time for right now, but please keep them coming to the Q&A button. And if you look, there should be even a chance to see the ones that have been answered, so they don't necessarily disappear. And thank you, Michael, for doing that. We're going to move on to Kimberly Tilley. Dr. Tilley completed her medical education and residency training at Emory University. She's worked in college health since 2008. And that's all been at the University of Southern California. So over to the West Coast and over to you, Kimberly. You're on mute still.
All right, thank you. Next slide. So our experience at the University of Southern California, which is also a large school, private though, we have about 40,000 students, a mixture of graduate and undergraduate. It's been very similar to what Dr. Deichen has had. We actually were not doing any telemedicine prior to March. We had launched a committee, we were starting to look at it. And so we launched all this like many health centers probably did, within a 1 to 2 week period in March. And we also had 20-minute appointments for most appointments prior to going to telemedicine. Now everything is standardized at 30 minutes. And I put on here, we have direct access. And what I mean by that is, in the clinic, the student first encountered the front desk staff and then an MA or LVN would bring them to the room. And now, we haven't had a way to really incorporate that staff into the telemedicine visit. So the providers are doing more of the administrative work. And, as soon as the student initiates the Zoom appointment, they're going straight to the provider. And then we've also had, with this, it's given us the opportunity to expand our hours. So we currently see students on telemedicine from 7 a.m. to 7 p.m. Monday through Thursday and 8:30 to 5 Friday through Sunday. Next slide. So when we started telemedicine, we started it in March. Pretty soon after that, by the end of March, early April, we said, well, how do we know we're providing the same high quality service to our students that we knew we were providing in person? We didn't have time to really give our staff more than an hour-long training on telemedicine, and we moved so quickly. So we sat down as a team and we said, what kind of metrics can we look at? How can we tell where we need to train people more and whether or not we're giving them quality? So we looked at these metrics. The first would be access, just how many people are scheduling appointments, how many are being completed, what's our no-show rates? Are we meeting all those population subgroups on our campus, or are there certain subgroups that aren't using telemedicine or don't have access to it? In terms of patient feedback, we have, a complaint system that we can use, but as well as we also always had our patient satisfaction surveys, but we also started a quick 3-question survey that the students get as soon as the telemedicine visit is done to get that immediate feedback from them. In terms of quality, we had done chart reviews in the past, and we had a template for that. So we redid our template for those chart reviews, and we started doing peer chart reviews to make sure these elements were there, and especially around the physical exam, because we didn't really have time to train people on what does a physical exam on telemedicine look like. In terms of sensitive exams, we had pretty strict policies here at the University of Southern California in terms of sensitive exams, and we needed to rewrite our policies and incorporate telemedicine into that. And then we also looked at our utilization. Where is telemedicine well utilized? Really thinking towards the future. What is the future of telemedicine going to look like at student health once we're not in a pandemic? Where does it work? Where does it not work? And then we have these proposed QI studies. We haven't gotten to those, but that's where we'd like to work on those over the coming months. Next slide. So to start with access, you can see here on the bottom bar, we have our different departments: primary care, women's health, dermatology, or dietitian. And you can see this is just in the fall 2020 semester on telemedicine only, the total appointments. So you can see in primary care, there's a little over 7,000 appointments. About 6,700 of those were kept. They checked into that appointment, and we had a no-show of 324, which was 4.6% of our appointments. Women's health, the same. There's about 6.7% were no-shows. And then we noticed with our dietitians and our dermatologists that our no-shows are about twice as much. So we've actually kind of dug a little deeper into those two departments to determine why are their no-show rates about twice as much as what we're seeing on primary care and women's health. Next slide. And then we also looked at just our primary care access, so we can compare by looking at our data reports, 2019 when we were entirely in person to now our in-person and our telemedicine this fall semester. And the way it works at USC is pretty much like when the students call in for an appointment, if they go on their patient portal to schedule an appointment, their only option is for the most part telemedicine. The only thing they could schedule online initially for an in-person would be a physical exam that they need for a school rotation or for athletic clearance. Otherwise, everybody has a telemedicine appointment first. And you can see, just because of the pandemic, because at USC, very few of our students were brought back. A lot of our students live out of state. Our volume of appointments is far, lower than what we'd had in 2019, but most are on telemedicine. But you can also see here that our no-show percentage has been consistent from what we saw in 2019 for in-person as now in-person and telemedicine. Next slide. And then moving to patient satisfaction, I mentioned we do that 3-question survey. So the first, this is just for September, but really all the months have been pretty much consistent. The same percentages. So the first question is, I was satisfied with my telemedicine visit, and we have over 95% of the people strongly agree that they were satisfied. And then next question, or next slide. The next question is, I would use telemedicine service again. And again, over 95% of our students agreed that they would use it again. And I would say that the third question is actually a comment section. And I would say most of the students, the positive is, I never thought that telemedicine would work for this. I was pleasantly surprised. I loved it. Please don't, please continue this even after the pandemic. We get a lot of answers like that, where they were doubtful, but they were really surprised how effective it was. Even for things, we put our physical therapist on telemedicine, and people have been thrilled with physical therapy on telemedicine. And the disagree is generally in 2 areas. Either they had some technical problem and they didn't understand how to use it, or they felt like they needed to come in and they felt like this was just an extra step before they could get that in-person visit. Next slide. So this is our chart review. I mentioned we've done 2 chart reviews now, one in the spring soon after launching telemedicine, and then we did one in October to look at our fall peer review. And so this was formatted from our prior one. So you'll see the first 3 were ones that we switched from what we had as a chart review template from when we saw people in person. And that was, as part of the template in the health record, they need to confirm that they have the right person with 2 identifiers, and they can check a box for that. There's also a box to check that the FERPA consent was signed. And then is the patient located in the state of California? Quite a few of our students live out of state, and we aren't able to serve students that are living out of state. One of our KPIs this year is chlamydia screening, and so that was in there as well for the fall chart documentation. And then the others are pretty similar to what you would expect in a chart review in terms of meds, allergies, and appropriate telemedicine, physical exam, lab studies, consults. Next, and I will say each provider that was doing these had 10 done at each time. So 2 different people reviewed them, 5 charts each. Next slide. So here's a table of our chart review from April, May, and then from August, September. And that's when the visits took place. And there were only 100 charts in April, May, because quite a few of our faculty were either furloughed or they had been redeployed at that point to other areas of the health system. But you can see under the 2 identifiers, we were initially in the first one, 86% of the charts that was, the person had checked off on the chart that they had done 2 identifiers. We got that up to 99.5. And mainly that was by making adjustments in our templates. So it's there and so people can easily just check it. Same thing with the FERPA consent. We made it easier in the template. We also did use our front desk staff to comb the schedule in the morning and reach out to people who hadn't done that so that that would be done for the provider before the visit started. Same thing located in California. We had our front desk staff start combing the schedule because it's pretty easy on our schedule view. The student does have to state what state they're in. The chlamydia screening we hadn't done the initial time, so we did do that in August and September. And as you can see, we have an opportunity there. The meds and allergies, again, we made that for some reason when we converted, that wasn't a hard stop. So we made that a hard stop again. And so now that's pretty much almost 99% of the time. The appropriate telemedicine exam, that was an area we put a lot of effort into because we're at 84%. We've gotten that up to 91%. So we've been pretty intentional. We had our physical therapist come over the summer and give us sessions on back and neck pain and really show us what she does on telemedicine and ways to assess those and how you can document in the chart. And then once she gave those, we also had our informatics go in and update our templates. And so people can have check marks and just like we use templates other times to really lead people towards the exam that they can do on telemedicine. Same thing with cough and URI. We had a hand wrist session. And then one of our providers did a best practices, how to do a website manner. Again, with the physical exam, what can you visualize and document and what can the patient assist you with on a physical exam and how can you document that? And then the others, like I said, are pretty similar to what we've done in other chart reviews. And next slide. And so with the trained assistants for sensitive exams, in person before the pandemic, we require a trained assistant for all sensitive exams. And there is no option to opt out of that. And both the provider and the trained assistant will document in the encounter note that they were there. And all the trained assistants have actually completed a training program on what is normal during a sensitive exam and how to report that if they're concerned about what they're seeing. And so we did go in and revise our policy that, we discourage doing the sensitive exams on telemedicine, but we realized that some students, there just may not be an option for them to come in and it may be necessary to do. And then we're going to bring the trained assistant onto that Zoom meeting and they'll do those same documentation requirements for those sensitive exams. Next slide. So utilization, one of the things we're looking at, and really this is more towards moving towards the future, is like what works, what doesn't work for telemedicine. And so I just gave some examples here, and these are reasons for visits. And so we have a report that shows how many people that had a reason for abdominal pain, that's scheduled for some kind of abdominal pain, had to visit them in person within 3 days. And you can see 12.7% of the time. And our conversion just overall is about 9% in primary care. So 9% of visits start telemedicine within 3 days. We're seeing them in person. It may not necessarily be for the same thing, but they are coming in within 3 days. But as you can imagine, things like insomnia, our UTI symptoms, actually, I don't have it on here, but contraceptive management, very few of those convert to an in-person, but things that need procedures like our warts, you know, looking towards the future, we may or may not even offer that telemedicine to start with, because 58% of people who schedule because they have warts are being seen in person within 3 days. Same thing with ear problem. It's just really difficult for providers to assess the ear since they can't look in the ear. So 35% of those visits are being seen within 3 days for an in-person visit. Next slide. And so another thing we look at is with our providers, is there a difference between that we can't explain between providers? So this first side is primary care. And so I just picked 3 of our providers out, and I can, based on that report, I can tell you within 3 days how many of the visits that they see on telemedicine are coming back and needing an in-person visit within 72 hours. And of course, we want some people to come in because not everybody can be assessed appropriately on telemedicine, but we don't want a wide, you know, if someone has a variation that's not explainable, we need to, you know, reach out and see why either they're having a lot more people or a lot fewer come in. But you can see here with the 3 I chose, pretty much everybody is about 9 or 10% of their visits on telemedicine are coming in within 72 hours. On women's health, on the other hand, you can see that a few more come in for women's health because they identify they need cervical cancer screening or they need an exam. And you can see the average is about 16-17% of people with women's health need to come in for an in-person visit within 3 days. But you can see here where provider D is sitting in 24% of her patients and provider E is in 13% of her patients. It may be that provider D is, you know, assessing more and realizes people need pap smears more and is sending them in, and provider E isn't. But it may also be that we need to train provider D to feel a little more comfortable managing on telemedicine. Next slide. And then this is my last slide. So creating a future of telemedicine at Student Health post-pandemic. And so we're really looking at these areas. These are, you know, kind of our core areas with our college health population, the chlamydia screening, depression screening, really making sure we're getting our students still in for immunizations and substance use screening. I will say right now, we've really encouraged, because we've given the providers that extra 10 minutes to do the depression screening, to do the chlamydia screening, we're encouraging them to look through their immunizations during that visit, no matter what the visit is there for, if it's appropriate, and have them come in. They can still schedule them to come in for a nurse visit for those immunizations. But we'd like to incorporate that more through our technology into the visits. And then access, do we continue the extended hours? And what is the appropriate length of time? Like Dr. Deichen said, we've had to go to 30-minute visits. And then how can we serve our out-of-state students? How can we make sure, especially as students come back onto campus? Right now, we're so de-densified. Will we have private locations and the resources for the translator assistance? And then last, we're always looking to do more training for our providers. One of the things we do now is we have twice a month CME lectures. And when we have those lecturers come in, if they're talking about concussion or whatever they may be here talking about, is to incorporate how can you do whatever you're talking about on telemedicine as well. And then also last is we do have our 4th-year medical students. We're going to get a residency soon and continuing to incorporate our educational training programs in our telemedicine visits as well. That's all.
Thank you so much, Kimberly. I just have a couple of really quick questions for you before we go on to our 3rd speaker. And the first comes from Rachel Kinney about the no-show rates. First of all, congrats on including some quality improvement issues. That's really, I think, the next step of a telemedicine program. But she asks, how do the no-show rates for primary care, women's health, and the dietitian visits compare to your in-person no-show rates?
So one of the slides did show that for primary care, they're exactly the same. They're all about 4%. So it's exactly the same.
Great. And then you got into a little bit of how to sort through which types of visits are really better suited for telemedicine versus in person. And a question came in about just doing standard physicals via telehealth. Are you doing those?
Yes and no, not athletics, definitely, because there's such a cardiovascular history that's so imperative there, and most of them have to get blood work with it. We will do some if, especially like for our med students in the fall, they needed the physicals before starting residency, and some of the residencies would accept it. And so we will do that, especially if they've been recently and we have a blood pressure in the last year. For those, we'll do it on a case-by-case example. But for the most part, that's why our physicals are the one thing that the student could book online without a telemedicine if they needed to.
And just final question really quick. Are there any types of visits that are just completely out of bounds that you think an in-person visit is absolutely necessary, like controlled substances, or you mentioned things that require procedures like warts? Do you have a way of categorizing things just to save everybody's time and not waste it on a telehealth visit?
I think definitely procedures, but even then, quite honestly, quite a few people with cuts, you know, I think we're all in college health. We know sometimes people schedule for paper cuts and things that are quite easy to manage on telehealth, but those procedure visits, the wound care, really do need to be coming in. You know, in terms of, we have a pretty strict policy in terms of narcotics and what we'll give here, so we see very little of that, but we've been pleasantly surprised with ADHD, and I think moving forward, we'll probably have most of those on telehealth since we see them every 2 months, with maybe once a year come in for a blood pressure check. I think we'll probably, that's an area we're really looking towards doing mainly telehealth in the future.
Okay, fantastic. Thank you so much for staying on time or moving into the third talk here. And it's my pleasure to introduce Gus Jordan. So we went 2 large colleges from the East Coast, West Coast. Now we're going to a smaller college environment. Gus has been at Middlebury College since 1996. He oversees the work of health services, counseling, health and wellness, and education, and sports medicine. He's a licensed psychologist in the state of Vermont and is published on topics ranging from academic dishonesty and professional ethics to family structure and its relation to depression in children. And he's past president of the Vermont Psychological Association and serves on its ethics committee. So take it away, Gus.
Thanks very much. Great to be with you. I am going to shift gears a bit and focus on mental health considerations and how we've responded to the current crisis. First, a little bit of background, and if we could go to the next slide. Middlebury is a small liberal arts college of about 2,500 students located in Vermont, so very different from the other 2 schools that we've talked about today. Our students, however, come from all 50 states and upwards of 30 countries around the world. We also have dozens of Middlebury-run study abroad programs across Europe, Asia, Middle East, etc. We had established a pandemic response protocol a number of years ago and watched carefully as COVID-19 spread this year. Still, we found the decisions concerning when to close programs and sites were made only at the last possible moment. We closed our China school at the end of January, our schools in Italy in late February, and finally our Vermont campus on March 13th. Students had only days to pack rooms and leave campus, and were returning to almost all of 50 states, some internationally. Our medical staff worked quickly to shift care to home providers. Unfortunately, students with chronic conditions tended to have home providers readily available. So not in every case, and I'll briefly talk about that a little bit later. Counseling, on the other hand, faced some immediate challenges. Next slide. By March, we had seen about 26% of the student body in counseling, the week that we closed, we were seeing 7% of the student body. Importantly, most of our clients requested to reschedule from home, and this posed an immediate challenge, one faced by schools like us and universities as well across the country. And as you know, licensing laws and statutes for mental health providers are almost exclusively state specific. In our case, they're even profession specific, such that psychologists, social workers, mental health counselors, each have different licensing boards, rules, and statutes to contend with. In addition, states tend to limit practice first to clinicians licensed in their respective state. That is, you can only practice in Vermont or California if you're licensed in Vermont or California. And second, practicing in a state is typically defined by where the patient is physically located at the time of the counseling session. And as I said, most of our students were heading out of Vermont. Next slide. So we had some ethical considerations to consider here. I want to talk about 3 that we were forced to evaluate really quickly. First, according to the American Psychological Association ethical principles, there is a conflict, or if there is a conflict between ethics and the law, psychologists, quote, take responsible steps to resolve the conflict consistent with the general principles and ethical standards of the ethics code. That is, you can see here a bias in the direction of the ethics code. And that was important to our considerations and how we navigated through the beginning of the pandemic. Next slide. Second, psychologists, quote, make reasonable efforts to plan for facilitating services in the event that psychological services are interrupted by factors such as a patient's relocation or financial limitations. In the spring of 2020, we clearly had failed at that particular ethical criteria. Although we had thought some about these things, we really hadn't thought through the effect of state licensing rules. Next slide. And third, psychologists strive to benefit those with whom they work and take care to do no harm, as in other professions. It's a familiar ethical principle. For psychologists, this overarching principle specifically also includes in our ethics code that we provide pre-termination counseling and suggest alternative services that providers and providers as appropriate. This means that attention to continuity of care, though not without limits, for our patients, regardless of state regulations, was important. Psychologists are not alone in this. The American Mental Health Counseling Association Ethics Code says, quote, continuity of care is crucial and at times may conflict with local laws and regulations. Counselors should employ a solid ethical decision-making model to secure continuity of care, unquote. Thus, in addition to confidentiality, ensuring continuity of care is a central aspect of the work that mental health professionals provide. Next slide. So what do? We provided rapid continuing education on telehealth for all of our clinical staff. We monitored emergency proclamations in states where our students resided, where they were headed home. We obtained temporary state licenses where possible, but that proved pretty unworkable quickly as states begin to make changes and emergency proclamations without much notice or consistency across states, especially around what they were requiring. We probably could have managed just in the Northeast, but it became really difficult as students spread out across the country. We provided short-term continuity of care focused treatment. So this was a big decision that we made in our staff, which included up to 3 weeks of counseling for low to moderate risk students, longer treatment if a student was considered at high risk or if the student had insecure housing and was transient across multiple states. We evaluated these situations on a case-by-case basis, and staff consulted with their clinical supervisors as they needed and documented decisions and rationales. Let's go to the next slide. Let's see, I think we've gotten through most of that one. Sorry, I jumped ahead a little bit. Okay, so if we could go to the next one. So some other considerations that we found essential to consider included confidentiality, certainly. The technology certainly had to meet appropriate ethical standards for privacy. But in addition, we found it important to make sure that our students were able to maintain their own privacy during telehealth encounter, something we haven't talked much about today, especially as many students returned home where they had limited privacy. So we worked with students on identifying places where they could engage our clinical staff in a private location for themselves, including, for example, students who would go sit in their parents' car during the counseling session in order to gain that kind of privacy. We also established crisis management plans. On each call, we confirmed and listed in the record the student's exact address, reminded students of our 24/7 crisis support options, which fortunately we did have. And we established callback plans, usually a telephone number in case the technology failed during the encounter. Next slide. Longer term solutions. One is SciPac. Over the summer, we began to explore longer term solutions. SciPac is a process that covers psychologists in multiple states, allowing them to practice in multiple states. However, there are several drawbacks to it. One, the number of states is really small at present time, and it only is applicable to psychologists and not other mental health workers. And also Vermont is not a member of SIPAC. So next slide. For us, a longer term solution was a national telehealth platform. We contracted with a national telehealth company to be up and running by this past fall. We wanted a platform that provided immediate 24/7 crisis stabilization and support available internationally where possible. That's not possible in many cases. We also wanted enough regular scheduled counseling to address most mental health issues, which we interpreted as about 12 sessions per academic year. In addition, we wanted telehealth medical and psychiatric care across the United States to provide equity of access to care for our students if and when they have to return home. And in fact, they all just returned home just before Thanksgiving break and are finishing up their semester now from home. Next slide. In addition, we wanted rapid implementation in the fall. We had a relatively seamless experience. We wanted a relatively seamless experience for our staff and our students. We call this our one staff concept, such that the experience for students is relatively the same regardless of how or where they access care. This includes what we call mid-health, which stands for Middlebury Health, and is care received on campus provided by our staff, and mid-telehealth, which can be accessed via the telehealth platform on or off campus, and is provided by a company with whom we contract. With respect to continuity of care, we wanted our encounter notes uploaded into our electronic health record system, regardless of how or where a student accessed medical or mental health care. Next slide. And this is the final slide for me. We also wanted a platform that would be useful to us after the pandemic is over, and particularly to help with 3 challenges unrelated to this particular crisis. These include increasing our ability to manage surge capacity, such as when flu season hits or requests for counseling overwhelm counselor availability, flexible appointment options, and flexibility for after-hours care for our students, and finally, continuity of care for students who take medical or mental health withdrawals during any given semester. I'll say as a last point that our students so far have been very satisfied with our new telehealth options, giving their experience with the platform patient satisfaction of about 4.7 out of 5. So why don't I stop there to make sure that we have enough time for a few questions before this ends.
Great, Gus. That was a great discussion, and thanks for bringing your perspective. So I think I'll just pitch it back to everybody if we could bring all of our panelists back on. And I also wanted to acknowledge Robin Buxbaum, who's been a ghost panelist answering some of the Q&A there. Thanks for pitching in there. The first question is a real general one. Just if you could answer briefly, why and how is telehealth for a university health center different from telehealth for other medical organizations? Kimberly, why don't we start with you for that one?
Oh, you know what? I'm sorry. I was reading some of the questions. Can you repeat it?
How and why is telehealth different in a university health environment compared to a regular healthcare organization?
You know, I think there's probably a lot of similarities, but, you know, we have a different patient population than other scenarios would have. You know, I think our experiences, there's probably fewer chronic health conditions that you're managing on telehealth, and it may be more acute conditions as well. As I think what's important is we do have this population that's really our population. So I see this more as like continuity of care for our population, where we're doing telehealth as well as in person, and we're doing both. It's just different means to provide care to the same population, as opposed to if you see an outside vendor that we all see advertised, it might be more like an urgent care kind of scenario where they don't have that lasting relationship that they're building. Where, you know, again, like I put in my presentation, we're really trying to incorporate this in our whole healthcare, you know, what we offer, and so that we can do our population health and telemedicine as well as in person.
Any comments, Michael or Gus, to add to that?
You know, I would say, you know, college health is unique whether it's telehealth or in person. We have for us, our population's prepaid, so we have a responsibility to serve them. They're also, they're young adults that are internet, IT savvy. It's a really good match for this type of healthcare delivery system.
Okay. Anything, Gus?
The only thing I would add is we're also finding that our students are becoming really good at it, whether they're talking with us on campus or our vendors that we work with, that it's just becoming seamless for them.
Yeah. Great. Question came in from Damaris Perkins about peripherals, which is sort of connected otoscopes or connected dermatology lenses. Are any of you incorporating peripherals into the care that you're giving? I see shaking heads from Gus and Kimberly. Michael, anything?
We talked about it. We've just not yet taken that step. I would imagine over time it might be possible, but there's an expense, and I guess we haven't quite yet decided where is our balance with telehealth, but I would think at some point that it's a consideration. Sorry, Kimberly.
The only thing I would add is, and I'm sure anybody who's done telehealth with skin conditions would attest in this, the resolution from a camera is so much better than what you can see on the video screen. And so I know our dermatologist, they actually, one of our staff members reaches out in advance to the student, and we have them submit photos with instructions on how to submit a good photo. I'll do the same in the middle of my visit. I'll say, send me a photo, because it's really the best way to really see the skin well.
Good point. A question came in from Laura Wasserman about what's going on your campuses regarding COVID testing for your students and staff. Let me start up with you, Gus.
Yeah, we were doing testing twice a week and with staff every other week, at least staff that were coming on campus. So very frequent testing.
Okay. Michael, how about you?
We have very much a layered approach. Our school is so big where we have an app for daily symptom screening, but then we also have routine testing available. This PCR based here, drive-through garage. We're doing random testing of all students every 2 weeks, and then we're also doing testing when students move back in at the beginning of the semester. It's interesting because we're using different testing platforms. We're starting to get into point of care antigen-based tests, for example. So I'm excited. I think we're getting to a much better place with testing.
Kimberly?
For the fall semester, we used an outside vendor to do our surveillance testing. It was not mandatory for anybody, but it was offered to all employees and students, whether they were living on campus or not. And then for our symptomatic and exposed, they had to schedule an appointment for us for an interview, and then we sent it to the hospital. For the spring semester, we will be expanding that, and to come onto campus, you will have a certain cadence, kind of depending on who you are, that you will have mandatory testing to have access to campus. And we are actually going to be deploying a mass testing screening module to, right now there's a lot of manual work in terms of someone having to schedule the tests, so the students will be able to schedule their own tests for surveillance and symptomatic and exposed.
Thanks. And I just want to sneak in one or two more before the hour gets away from us. I feel like I got a slightly different answer from each of you on out-of-state, being able to treat out-of-state patients. And somebody asked you specifically, Kimberly, why you can't serve the out-of-state students that are coming from out of state. It sounds like Michael took a little bit more of an approach like, well, the HHS has given us a little bit of a green light. So if you could just address what's going on with out-of-state folks. Kimberly, you first.
So, from our attorneys at the hospital, they have told us in the state of California, because the state of California in the map that Dr. Deichen put up, says that you can't, that nobody can treat people in state if they're out of state, but they've interpreted that as we cannot treat any students that are out of state. They have to be in the state of California for us to treat the student. We have a way through our legal team that if someone really needed it to continue continuity of care, we can ask for an exception. but it's quite a bit of work. And we've only used that a couple times on some of our students who really had a unique medical reason that they needed to continue the care.
Michael?
Yeah, it's challenging. And for us, most of our students are in state. So it's more the exception rather than the rule. And there are systems in place that make understanding the various state regs easier. We used a product that was published by the University of Texas at Austin to quickly assess what are the state rules when we have an out-of-state patient. Our legal hasn't restricted us from doing that, but it's not something we've used a lot.
And Gus, it sounded like you took sort of a middle road with temporary licensing and a third-party vendor.
Yeah, that's right. And I would say our response was very similar to Michael and Kimberly's with respect to medical care. I was addressing mostly mental health care as being a little bit different in the way we approached it.
Okay, outstanding. Well, the hour has gotten away from us. Thank you so much for all of your presentations and fielding the questions. I'm happy to turn it back over to May to close out our session.
Thank you, Dr. Ramers, and thank you to our panelists. And also, Dr. Ramers mentioned Robin Bussbaum from the American College Health Association, who helped put this session together. Know that there will be a second part on Thursday, December 10th, and it's setting your campus telemental health program up for long-term success. Our January session will be on the pandemic response, so please note that that information is there on January 13th and January 27th. Again, if you are interested in CME credits, please go to the Learn on Demand website to download that information and get your credits. Once again, thank you to all of our panelists for today's great session, and thank you to Dr. Ramers for hosting, and thank you all for attending. Have a great day.